My student down.
I don't mean to laugh. Dramatic deglovings, someone get a crash cart stat, and uh-oh, med student down. Today, I'm very excited because we are getting a taste of the medical chaos that I deal with on a daily basis as an emergency room doctor. All from a brand new medical show called The Pitt. Let's dive right in.
42-year-old male, Sam Wallace, blunt head with agonal respirations. Dropped down on the T-tracks. Couldn't tube him, LMA in place.
Suicide attempt? Rescue.
Oh, very interesting. Agonal breathing, so his respirations are not adequate. And then they put an LMA, so a laryngeal mask airway, so it's a supraglottic. So if you need a quick airway, you could put this device in.
Woman fall from T platforms, good vitals, no head injuries. Degloving injury, right lower leg with open fracture dislocation of the
Oh, ouch. Degloving injury meaning that the skin and some of the subcutaneous tissue have been removed like a glove, meaning like turned inside out and peeled off.
Good breath sounds bilaterally, but we need to protect his...
Apparently, he jumped down to save the lady. When he climbed back up, he slipped, fell back and hit his head.
It's more of an RT procedure. Mel, right? I need you on the E fast.
They're working him up as a trauma. Likely that there's going to be a trauma surgeon coming down. The emergency team gets it started. So doing E-fast, you're basically looking at quick to see if there's any pneumothorax, as well as the fast exam is the focus assessment, sonographic exam, and trauma, basically.
Pupils 4 millimeters and reactive.
Okay, that's encouraging.
So describing the pupils, the size, and that they're reactive. So that is encouraging when somebody has a head injury, especially when they're agonal, because if they're not reactive or they're sluggish or that they're different sizes, that's concerning for intracranial abnormality.
What do you want for meds?
120 ketamine, 80 of rock.
AFib on a monitor.
120 milligrams of ketamine and 80 of rock. What do these mean? These are medications that you would do for a rapid sequence intubation because they're going to take out the LMA and they need to put an ET tube in.
Students,
20 cc's of
what might have made her faint on the platform?
Could be an
TIA,
arrhythmia, cardiac
CVA.
event,
So she needs
EKG, and troponin.
Okay,
You
good,
got pretty
good.
people.
So you hear 2 grams cefazolin, so that's an antibiotic, so they're giving it early in the setting of a bad open wound like that. But I do like to see that everybody's in their PPE. They got eyewear, they got gowns and gloves on.
My student down.
I don't mean to laugh. So once you put it back into place, you need to splint it so it doesn't move again and get an x-ray to make sure that it is where you want it to be. If not, you need to do it again, or the person needs to go to the operating room sooner than later. People do pass out in medicine. The majority of the time, it's due to the fact that you're either holding your breath, your vagus nerve gets involved because you're seeing the issue as like a total person problem, blood, versus looking at it as a problem that you need to fix.
Temp 98.2. Take a deep breath for me, Otis.
Little pinprick now, okay?
Oh, passed out. Check a pulse, make sure you're breathing. But you'd be like, oh gosh, put on a cardiac monitor, get staff to help you, that sort of thing.
No pulse. Crash cart,
Oh,
laying flat.
that's scary. The crash cart, you hear it all the time, has a defibrillator on it, has medications that you would need for cardiac arrest, has all the emergency stuff. But you need to lay this person down quickly, get CPR started, put an AED on, get rescue breaths going.
How you doing there, Otis?
Okay.
What happened?
VTech again. 200 joules.
Charge.
So that was quite accurate. You know, you charge it to 200 joules. Typically, you would then continue to do CPR for 2 minutes and then check the rhythm. You can be in an abnormal rhythm with a pulse and just do this type of cardioversion versus defibrillation when the patient is pulseless and you're trying to prevent their death.
And clear.
Back in sinus.
What are you doing?
1 gram calcium glutamate, IV push.
We don't have the labs back.
Click the monitor. Wide QRS and peak T waves, hyperkalemia.
How do you get that?
All medical jargon basically meaning everything is back to normal, describing the event and that his vital signs, blood pressure and pulse are good.
Intense exercise caused muscle breakdown, rhabdomyolysis, knocked out his kidneys. Now he's not clearing potassium. I bet it's over 7.5.
Wait 2 minutes for the ice.
If you arrest him, we might not get him back.
Calcini, you could kill him. Wait.
It's my long story. Dr. Collins will fill you in.
I mean, he's an actor doctor, but that's pretty accurate. So we're talking about elevated potassium levels, probably due to muscle breakdown, rhabdomyolysis, and renal abnormalities because of all the training that he's done.
You know, we gave you medicine to lower your potassium, and you'll need dialysis to clear it all out.
Then I'll be okay.
Yeah. You might need a week or two for your kidneys to recover, but yeah.
There you go. So he had hyperkalemia, high potassium, and they say that he needs dialysis. You don't necessarily need to jump to dialysis if they have normal working kidneys, but if the kidneys by lab work are shut down so badly, you might need to do dialysis.
Gonna miss the morning arrival of the living dead.
How many are we expecting?
We're getting 3, but 1 died en route. I don't know who's luckier, us or them.
What's open?
What they're describing is kind of common that happens in the morning when they do rounds at nursing homes. They find individuals that don't have pulses, and so a lot of 911 is called early in the morning.
89-year-old woman from a SNF, history of emphysema, CHF, MS, VFib, unresponsive to 3 shocks, 2 rounds of epi.
VFib, unresponsive to shocks and epi, so standard protocol. And so this individual is on the Lucas machine, which is basically the machine that's doing CPR for you and appropriately put on. All very good. Typically when you're bringing in a cardiac arrest into the hospital though, you are moving a little faster.
Everybody get a hold. 1, 2, 3.
Oops.
Students are dropping like flies.
Take a break. Ice the finger.
I mean, it does happen. Any job, somebody could injure themselves, but in medicine, it's like, okay, if you're not able to help, just don't get in the way. People injure themselves a lot at the hospital, lifting a lot of people, moving them around, and your first concern is always for the patient. You forget your own body mechanics, and sometimes you can injure yourself. So
You can count on getting a couple elderly patients every day around 7:30 after the nursing homes and assisted living facilities do their morning bed checks. You can practically set your watch.
Was there an advance directive?
No, full code for the nursing home.
Seriously.
Lucas off.
it's appropriate to ask that, and do they have an advance directive? In California, we call it a pulse. Do you want CPR? Do you want to be intubated? Do you want to be put on a machine? Or do you want comfort measures only? But it's really important to have advance directives, especially in your nursing facility. And the reason why they're frustrated is this person has long-term major chronic medical conditions that are not really recoverable. They're manageable, but not very recoverable.
Still VFib.
Lucas on. One more round of epi, one more shock, and then we call it?
Okay, let's move her to the viewing room and notify the family. Yeah. One of the things we do here is to take a moment of silence when we lose a patient.
Pretty accurate. Sometimes patients will come into the emergency department. You'll do a couple rounds of CPRs and call it. They don't do it in the field. It's because there may be another intervention that they may not be able to see that we could see or do at the hospital. But ultimately, if patients have a long downtime, given the appropriate care, it's time to unfortunately stop.
Hi, I'm Dr. McKay. What's going on?
I found her on the floor in the bathroom. She can't stop puking.
What's her name?
Teresa, she's my mom.
Scenario that's not that unique, where even myself goes into the lobby of the waiting room. You're getting stared at by all the patients. They need our attention. The emergency department is not a first come, first serve. It is a treat and deal with the most life-threatening, limb-threatening problems first, and then prioritize length of stay.
No, I never go anywhere. She can have to stay here.
Oh yeah, I need a fresh set of eyes.
On what?
54-year-old woman brought in with intractable vomiting by her 18-year-old son. I'm getting a weird vibe.
Hi, Dr. Robbie. We need to do a pelvic exam.
So that's pretty good. So the doctor has a weird vibe, so gestalt or feeling, and that is huge, and you have to be aware of that and use it to your advantage. You have to kind of get a sense that, okay, something's not right, so we got to investigate a little bit further. You don't want to be accusatory, but you also need to be direct. So there are a lot of medical shows out there, but I have to say this is probably one of the most accurate. Whoever was their medical consultant did a really good job. So I want to know what you guys think about the show, about the react. Let me know in the comments, and make sure that you watch this playlist right here, binge watch everything. And please turn on your bell notifications, hit that like button, and don't forget to subscribe. Thank you so much for watching, and stay healthy, my friends.